This lecture is about ClinPath sample submission and common issues that we see with sample submission and common questions that we get about some of the results that we put out. So we'll go ahead and get started. I do want to say I am going to post this PowerPoint and video in the J Drive in the 5-minute rounds folder for WSU students. And then I'm also going to pop the PowerPoint into my Google Drive, and I'll link that in my link tree that's in my Instagram profile. Okay. So just some general sample submission stuff. Make sure that you label the tubes at the time of collection. So occasionally people come back and say, oh, I labeled that tube incorrectly, or oh, those the labels need to be switched. Those are different patients. And that makes us very nervous. So just make sure that that is done at the time of collection. And don't ever let a tube sit unlabeled ever. So I think that's just a good rule to abide by forever, because it comes up more often than you think, where you're just like, oh, there's multiple tubes sitting there, what's what? And then when you're filling out the submission form, make sure that the doctor that's listed on the case is actually the doctor that we can contact for more information on the case. So a lot of times the doctor that's listed is not the doctor that we can contact, and that just slows things down if we need more information. Also, if the student wants to be contacted or a technician wants to be contacted instead of the submitting doctor, then you can go ahead and put that where you would put the history. You can also add that information and give us a phone number, and that makes things go much faster as well. Also, make sure that you're submitting an accurate history. And I have some additional posts in my Instagram about this. And I could talk about this with you forever, but especially for cytology, why did you submit the sample? What do you think is going on with the patient? What are you worried about? What do you want to rule out? Is there a travel history? If there's a specific infectious organism that you're worried about, please let us know. And then if there are preliminary imaging results, then that is very helpful. Especially if radiology is kind of getting backed up, then we won't be able to access their reports. And it's if you have some preliminary results, then go ahead and pop that in the history as well. And then for CBCs, a lot of times the history that's on the CBCs never gets changed. And so that can be kind of confusing for us if we're looking at patients that have lymphoma or like a CLL, then we have to like pull up previous CBCs to try to figure out what's going on, because it'll just say something like vomiting, but that was actually the reason that the patient presented 3 months ago. So that will be really helpful to us. And then, if there were previously atypical cells seen, if there was a concern for a stage 5 lymphoma in a previous CBC, that will be helpful. Or even just like, I think this patient has IMHA instead of lethargy, or I think this patient has mycoplasma. All of those things will be very, very helpful to us. And then submitting the appropriate amount of blood for the lab work that you have requested. So often we get very small amounts of blood that are just not enough for what you've asked for. So, be realistic. If you're not able to get that blood, that's one thing. For a lot of people, submit the small tubes if you have a small dog, but really even for anemic patients, I wouldn't worry about the amount of blood that you have to draw for, a CBC chem. So, that just gives us a lot more blood to work with. So make sure that you're pulling the appropriate amount of blood. And you can always come down and ask us. So some different tubes, I'll just go over this briefly. So the purple top, that's going to be for your EDTA. That's going to be your EDTA tube. That is usually a sodium salt that chelates calcium. And this is what you're going to be submitting for your CBCs. You're also going to submit fluids in this. This is what we use, the tube that we use to do fibrinogen and your plasma protein. So if you have an anticoagulant in the blood and you spin it down, that makes plasma. If you do not have an anticoagulant and you spin it down, that makes serum. Make sure that it's mixed well. We will not run this if it has a clot, because that will mess up our machine and cause delays for everyone else. So it is not worth it, and it will cause other problems for the sample as well. And then the red top, so there's no additive. As I said, after it clots and you spin it down, you get serum. This is what we use for chemistries. Also, you can put urine in these. There's just nothing in them. Fluid cultures. if when in practice, you'll have tubes, you may have tubes that have this gray swirl and that has the serum separator. These are also called tiger tops. So if you have these in practice, you'll spin these, the serum separator will go between the blood and the serum, and then it can sit like that. So you don't have to pull off the serum. It's supposed to be faster. So you don't have to deal with that before you send out the sample. But if not all of the blood goes beneath the serum separator, then you need to spin it again or just pull the serum off by hand. Because if that serum sits with blood, it's going to cause alterations in your results. Make sure that when you're filling up your EDTA tubes, if you're also collecting a chemistry, and just in general, I would just make a habit of never inverting the purple top while you have the needle in, because you will contaminate the needle with EDTA. And then if you then put that blood into a red top, the contamination of EDTA is going to cause hyperkalemia and hypocalcemia. And they're usually like very wild and like not consistent with life. So it's pretty obvious, but then it messes up your sample. So no need to, do not invert with the needle still in. The way, and I get this question a lot, people ask if they should fill the tubes through the needle or if they should take the top off of the tube. I would just keep the needle on, put the needle into the tube and let the vacuum pull the right amount of blood in, and then remove the tube and start your inversion. And then you have, you know, whatever time to get it into the red top. It doesn't matter as much. You know, if you're just letting the vacuum pull the blood in, then you're not going to have problems really. People want to pull the tube off, pull the cap off the purple top and put the, you know, to be more gentler to the blood. So you're just putting it through the tip of the syringe. But really what I see is more often than not, those samples are clotted because it takes time to do that. And what's faster and fine is just putting the needle into the top of the tube and letting the vacuum suck the blood in. What I wouldn't do is really jam the blood in using the plunger, because that can cause hemolysis. But if you just let the vacuum pull the blood in, it's going to be fine. Green top, so we don't use these, see these very much in Clin Path, but we can run our normal chemistry panel on a heparin sample. We can't use this for a lot of other things. This also can't be clotted, but we can't use for chemistries if there are clots, and we can't use on a lot of our other machines. So the Advia, the Emulite, which does thyroid and progesterone, or the blood gas machine. And then the light blue top with the white label, that's our sodium citrate that chelates calcium. This is the tube that we use for PT and PTT. And these tubes need to be completely filled to get the proper dilution of blood to anticoagulant. And they should be spun within 30 minutes of collection and the plasma pulled off. And so these also need to be filled properly and mixed well. If there are clots, then we're not going to run it. And always ring the bell when you submit a citrate tube to us to let us know what the sample is for. The other reason that you may submit a citrate tube is if you had a lot of platelet aggregates in your CBC, then we may ask you to resubmit a sample in a citrate tube, and we can sometimes get a more accurate platelet count on those. I think I have another slide about this. So we get a lot of questions about this. So when we have a prolonged PTT and a normal PT, so there are some, you know, pathologic things that can cause this, like early DIC, but there are a few non-pathologic things that can cause this that you need to be aware of, and that we've seen happen in the hospital before. So contamination of the sample with heparin. Sometimes people ask me, does it really matter if the sample is contaminated with heparin? Yes, it really matters. It affects the PTT preferentially. And if it has a lot of heparin in it, it will eventually affect the PT as well. It usually has negligible effects with the amount that we see in samples. This is typically when someone has flushed an arterial line and then pulls the blood out of that arterial line right after. And then we'll see prolongation of PTT. Underfilling of the tube. So this is also something that preferentially affects the PTT. So if you underfill it by just 90%, so less than 90% of its fill, ideal fill, then you'll start to get prolongation of PTT. At which point this goes outside of reference interval. It's hard to say, and it depends. If the patient was high normal, this might pop you out of your reference interval. And so the more underfilled it is, the longer that PTT is going to be, and eventually that will affect your PT as well. So typically we'll turn away an underfilled sample. In bigger diagnostic labs, we'll often just run it anyway and charge you for it and tell you that it was underfilled, and it will artificially prolong the results. So just be aware of that. And then in cats, Hagman deficiency is a factor 12 deficiency. It doesn't cause any bleeding, but it will markedly prolong the PTT. So that's something to consider if it's a cat. With cross matches, if you've ordered a cross match, don't drop and run. Always ring the bell and speak with someone when you're submitting a sample for a cross match. And then I have a couple slides in here about making a blood smear. I'm going to do a separate post on how to make a blood smear, but this is just some tips. So generally in the hospital, you're not going to need to be making blood smears. We'll make them from the EDTA. But if for some reason you only get a drop of blood and you want to make a smear, there are some tips here on how to make a blood smear. I do highly recommend doing the pull back into the blood drop and push forward to make your feather, instead of I don't even know how to describe it, pushing the slide into the drop and then pulling back to get your feather. But I'll make another post about that. These are just some sort of guides for that. And this will be more important when you're in general practice. To be able to make a good blood smear, I think can be very powerful to be able to look at a blood smear, and there's a lot of information that can be there. Here's another just troubleshooting. And like I said, I'll make another post specifically about making good blood smears. And then really, for WSU students, I'm here until December, if you want to, arrange to meet me in the lab, I will teach you how to make a blood smear. And I have not been unsuccessful with getting any student yet to make a good blood smear. So I can help you if you think you are, it's not possible, I can help you. So I'm happy to meet with anybody and teach you how to make a blood smear. So this part is going to be a little bit overlap with the how to read a CBC lecture that I posted previously, but I just wanted to touch on some of this so that everyone knows this is what we're looking at when I look at a CBC. So this is your white blood cell count. If you have a corrected white blood cell count, it'll be right here. And I think I have an example of that coming up. This number here is your percentage of each white blood cell type. So this means there are 62% of the white blood cells that we saw, and we do manual diffs on every sample, are segmented neutrophils. And then the way that we get this number is this is our absolute count over here. So we're going to take our white blood cell count times the percentage that we saw on our diff, and that gives us our absolute number. So these are absolute counts. And then when you add all of these up together, this should be 6.5, which is our white blood cell count. So sometimes there are some glitches and VADs that may cause these numbers to be wonky. If you notice that something doesn't seem right, if these numbers don't add up to your white blood cell count, let us know and we can fix it. There is like a weird glitch in VADs that sometimes reverts the counts back to a previous diff. And sometimes we don't always catch that. So just let us know, we can fix that. So here is a sample that has a corrected white blood cell count. So even though this number up here says white blood cell count 32.9, it's high. That's not your white blood cell count. This is your white blood cell count. And the way that, sometimes people miss this and they're like, oh my gosh, I have a leukocytosis. And then I'm like, no, you don't. Well, this patient still does, but occasionally it puts, the number of NRBCs is so high that actually when you correct for the NRBCs, the white blood cell count is normal. In this case, it's still high. And it doesn't make a huge difference in this case. But another way to catch that is if you have greater than 5 NRBCs, then you know that you're going to have a corrected white blood cell count. So if you have greater than 5 NRBCs, you will have a corrected white blood cell count. So that should draw, if you've missed this the first time around, when you see this NRBC count, oh, it's greater than 5, I have a corrected white blood cell count. And if you don't, then you need to let us know. that's something that also sometimes there's a glitch that sometimes reverts that back to the white blood cell number, the original white blood cell count. So same thing, you know, this number, these absolute numbers are going to be from this corrected white blood cell count. So this would be 29.6 times 12% equals 3.552. And then these numbers should add up to our white blood cell count, which is 29.6. This is not our white blood cell count. This is the automated one that the machine came up with. This includes the NRBCs. So this is our actual white blood cell count, and this number should match that. And for NRBCs, that can be these metarubricites or rubricites. Often if I'm seeing a lot of rubricites, especially if it's, I think, an inappropriate like rubricitosis, then I'll put a note here that it's metas and rubricites, but not always. And then RBC morph is here. Oh, this is the equation for figuring out the corrected white blood cell count. We'll always do that for you, but in general practice, that may be some information that you want to know. And then for looking at a left shift, you want to add up all your immature neutrophils. So here we have bands here. There's a line for metas down here. And so you want to add up all of your immatures to see, you know, how many immatures you have compared to your segs. In this case, it is just a regular left shift. If the immatures were greater than the matures, which are here, the segmented neutrophils, then we call it a degenerative left shift, but I don't see that very often. If we had any cells that were more immature than that, then we may put that in the unclassified section, and we would put a note what those were. And so these are the immature neutrophils that we may see, typically bands, sometimes metas, really not common to see myelocytes in a normal inflammatory process, but possible. If we saw more immature than that, then I'd be worried about some kind of leukemia. And then for the toxicity, you can see we're going to put that, it's going to be under our white blood cell, automated white blood cell count. So here I said toxic neutrophils, many 1+ and few 2+. So that first word is also rare, is a word that we sometimes use. So rare, few, moderate, or many, that tells you how many neutrophils out of all of the neutrophils were toxic, had a toxic change. And then the 1+, 2+, 3+ is telling you how toxic they were. So Dolly bodies and mild basophilia, that's going to be a 1+, moderate basophilia with Dolly bodies, indistinct foaminess, that's 2+, and then 3+. Don't report that super often, maybe with like your, sometimes with the parvo cases. And sometimes, usually by the time they get 3+, sometimes they're just difficult to identify as neutrophils, and we're not sure, but we may say, these are probably neutrophils and they're very toxic. And then for this plasma protein, so if you ordered a chemistry, then we don't do a plasma protein. If you only ordered a CBC, then we'll do a plasma protein. So if you only ordered a CBC and this is still blank, let us know and we can run that for you. But that's why they'll usually be blank. Another thing that I get some questions about sometimes is if we note like rare mast cell in the peripheral blood of a dog. So that's something that happens occasionally, and it's not something that I would worry about too much if the dog does not have a history of mast cell disease. And even if they had mast cell tumors, it wouldn't alarm me to see rare mast cells unless they were atypical. You know, you may want to I would recommend working the patient up fully. But sometimes people see that I noted one single mast cell in the peripheral blood of a dog, and they're, you know, alarmed. For a dog, I wouldn't freak out about that. Most common causes are inflammation and regenerative anemia, neoplasia, other than mast cell tumors, trauma. So, you know, lots of things can cause it in dogs. And in this paper, this is kind of an older paper, but 99.5% of blood smears with mast cells detected during a CBC were from dogs without mast cell tumors. And the dogs that had the highest mast cell counts in the peripheral blood were not dogs that had mast cell tumors or mast cell disease. Cats are another story. So even if I see one mast cell in the peripheral blood of a cat, I'm very concerned, and I think that cat has cancer, most likely a mast cell disease, so like a visceral mast cell disease, and I'll recommend that you just sample the spleen. I think every time that I have, every time that that's happened, they sampled the spleen and it was visceral mast cell disease. So that's by far the most common cause of that. And even if the spleen looks normal, it can be full of mast cells. So that's an important difference between dogs and cats. Another thing that we get questions about sometimes is macrothrombocytopenia in Cavalier King Charles Spaniels. One thing, if you're like, oh, I have this Cavalier King Charles Spaniel, they have a low platelet count. I don't know if this is because they're a Cavalier or because they are going into DIC or something. If they've ever had blood work before in their life, see if you can get your hands on that, because if they have macrothrombocytopenia, then they always had macrothrombocytopenia. So it should be something that is always present in all of their lifelong blood work. If this is the first time that they have a thrombocytopenia, then it's not macrothrombocytopenia. And then so often for Cavaliers, the reference that we use to see if they have a normal amount of platelets is their platelet crit. So that's similar to a hematocrit, is we're looking at the actual volume of platelets, so their number and their volume, and their size, because these dogs don't have any bleeding issues, because although they have lower platelet counts, they also have very large platelets in their peripheral blood, and that makes up for it. So we look at their platelet crit, and we don't have a reference range at our lab, but we use this reference interval generally from this paper. And so as kind of a general guide, but I have had some Cavaliers that run a little bit low, but they always run at that number and they don't have bleeding issues. So, if we look back at their history of what their platelet crit has been, all the times that they've been in, it was, slightly below this reference interval, but it's normal for them. And typically doesn't change too much. So the ADVIA does calculate this platelet crit, so that will be on the actual ADVIA printout, but it is not in your CBC printout. You can easily calculate it, and here is the formula and an example of how to calculate it. But if you're like, I'm not sure, if I'm not sure if I did this right, I want to look at the CBC printout, we have that in the lab. Another thing that we get asked to do a lot is do a manual platelet count. If the reason that your platelet count is low on the ADVIA is because of platelet aggregates, which we've noted, then it's also going to be low in the platelet estimate from the blood smear. So the ADVIA uses a flow system, and so when it hits a it's counting, it's like, okay, I have one platelet here, one platelet here, one platelet here. If it sees a platelet aggregate, it might not even recognize that as a platelet. But it's going to underestimate. Let's say it only counts these individual platelets. It's going to underestimate the platelets because they're in these clumps. So when we do a platelet estimate from a blood smear, we're looking in the monolayer at these individual platelets, and that's how we come up with our platelet estimate. So if you have a lot of platelet clumps on the feathered edge, they're not evenly distributed throughout the blood. And so our manual platelet estimate is also going to be low. So, we can do a platelet estimate. It's not very accurate. The machine is much more accurate than we are. I think there are some situations where it's worth it to say, hey, can we double check this? If we think that the ADVIA counted something as platelets that weren't platelets, or missed platelets, for example, with macrothrombocytopenia, sometimes it doesn't catch those really, really large platelets. So the automated platelet count might actually be lower than it actually is in Cavaliers, because it's not counting the giant platelets. So there are some situations where that makes sense. But if the only reason is to say, just be aware that a manual platelet estimate from a smear is not going to be more accurate if the reason the platelets are low is because of clumping. So that's just something to be aware of. So be aware if you use the prelim function to access preliminary results. So like if we run a chemistry and one of the values is weird and we're going to rerun it, every time that we rerun a sample, it auto-populates again. So if you're looking, sometimes people are like, the results changed like 5 times. And that's because we were doing a dilution. So, there were like different numbers popping in there. We weren't done running it. There weren't multiple results. It's just that we hadn't finished running the sample. And so just be aware of that. If and also the albumin and calcium are the last things to run. So if there's an artificially low, or they'll be artificially low if there's a short sample, and those numbers will populate in, briefly until we have a chance to go in and delete them. But if you're, checking prelim results and you see that there, just, don't act on any prelim results until you talk to us, because they may not be accurate for a number of reasons. And then sometimes there are no reference ranges. So this is like for certain species, or sometimes things for puppies won't have a reference interval, or young animals. So it's difficult to put, reference intervals. Like you say, okay, well, I want to use reference intervals from a cow, even though this is a moose. It's difficult to actually put those reference intervals in VADS. It's just kind of finicky. But we're happy, we can give you that reference if you don't have one. We can give you what our like bovine reference intervals are, for example. But just be aware of that. So cytology sample submission. There are a couple links here to how to take samples. You'll learn that on clinics. I have some tips. I have what I did in general practice that I think worked well. As far as the sample collection, I do tattoo method plus or minus suction. So, you'll learn that on clinics, and hopefully, especially on oncology, they'll talk to you about sampling lymph nodes. And generally you want to be more gentle with lymph nodes and not use suction. I always use suction even on lymph nodes and got great samples. So my biggest tip is just, if you don't think you got a good sample, try a different method. I really, really encourage you to smear your samples like this. So, you put the two, you have your sample on one side, you gently lay the other side on top of that sample and let the sample kind of squish down, and then you pull the sides apart. And sometimes when you do them parallel like that, they'll kind of vacuum together and they can break the cells. So if you do them perpendicular, that's a little bit more gentle. The biggest things are don't press down on that top side. So just kind of set it there, but don't put any downward pressure because that can break the cells. For staining, DiffQuick, that's what you'll be using in general practice, and you have access to some of that on the floor. You're also, welcome to come use our stain, which is Right Gimza. And, we can't handle a ton of just extra stain only, but, for now, not a lot of people are using that. And especially if you think that you might want to turn it in to the pathologist later, because we like Right Gimza better. And then there are a couple limitations. So occasionally DiffQuick doesn't stain mast cell granules super well. And then, but it does stain distemper inclusions, usually a little better than Right Gimza. They kind of stand out more. I have a difficult time personally assessing lymphocyte morphology. I think all the pathologists struggle with assessing lymphocyte morphology on DiffQuick. So especially if it's a lymph node, we're going to want to Right Gimza slide if you're thinking lymphoma, especially. So just some common mistakes. So samples that are too thick are not smeared. So this is called the Starfish method. I highly, highly recommend not doing this. So this is when you just put the slides together and then pull them straight apart without smearing. So I really do not recommend this technique at all. And then samples that are just too thick, I can't see anything. So especially if they're very bloody, and like if I had a sample like this, I would maybe try to get less initial sample on. Sometimes if I smear it and it still looks too thick, then I'll smear it again. And you can also, if you have something that's very bloody or very fluidy, you can additionally make a prepare it like a blood smear. There are certain samples, like sometimes people submit liver samples that were prepped like a blood smear. I wouldn't recommend that. I would only, use that blood smear method in addition to a normal smearing method if you think that you did not have a good preparation. And with very fluidy samples, or very, very bloody samples. So these are some just examples of other samples that I got, that were just too thick. Additionally, like sometimes that's just the way the sample is, like, you know, sometimes it just comes out, it splatters the slide. And probably what I'm suspecting happened here is they splattered the slide and they didn't try to smear it right away. And so when they went to try to smear it, it wouldn't smear because there was such little sample that it dried almost immediately. So you have to be ready to smear the samples, especially when you have a very small amount like this. It's going to dry quickly, and if you wait it all when you go to smear it, you're not going to be able to. So samples are too thick or not smeared. I think people worry that they're going to break the cells, especially with lymph nodes, when they smear the slide. But if it's not smeared, I literally cannot see the cells. So it is almost always going to be non-diagnostic if it's not smeared. Some ways, and there are some samples where no matter what you do, the cells are going to break because they're fragile, because they're neoplastic, and that's just the way it is. But some ways to prevent broken cells: be gentle. So like I said, no downward pressure. Don't, you know, if you feel that the slides suction together and you feel a lot of drag, take another sample. And use a couple different collection or smearing techniques if you're not sure. You can always get feedback from us. And then keeping the slides perpendicular to each other instead of parallel can help decrease that chance of suction. I always use the parallel method and I got great samples. So that was just my experience in general practice. And then take more than one sample, so that increases your chances of getting a diagnostic sample. So another common mistake is only submitting 1 or 2 slides. So the more slides that are submitted, the better chance that one is diagnostic. So, you know, we typically get many slides, but I know there are some labs that limit the number of slides that you can submit per sample, or you get charged more. You know, here I wouldn't blink at getting 10 slides for a sample. And then especially if the slide looks too thick or it looks like it doesn't have anything on it, then take another sample and try a different technique. So suction versus no suction. If the sample is fluidy or too thick, try the blood smear technique. Also, if you collect fluid off of a mass, you can pop it in an EDTA tube and submit that. And then when diagnosing lymphoma, I recommend submitting slides from every lymph node that is palpable, whether it is enlarged or not. Well, I put lymph nodes are charged as one site, no matter how many lymph nodes are submitted. That's true when I was in general practice for IDEX and Antec. That may change, but that's how we have been charging lymph nodes. And then, so your submandibular and popliteal should always be palpable. And sometimes the submandibular, especially if your submandibulars are the only ones that are enlarged, that they can be difficult to diagnose lymphoma from, because dogs that have a lot of dental disease, they can also be reactive, and so it can be difficult to interpret. And then only submitting the diff quick stain slides, or not sending the diff quick stain slides. So one problem is you took one sample, you only have one slide, and you stained it with diff quick, and that's the only slide you submit. A lot of times they're diagnostic, but sometimes it's difficult, especially with lymph nodes. And so we recommend submitting unstained slides as well, and that's especially important for if you're in general practice. And then not sending the diff quick stain slide. So sometimes it's the only diagnostic slide, and it's fine, especially like sarcomas are fine to diagnose from diff quick stain slides. And there's other things that are fine. So occasionally I'll call the clinician and they'll say, oh, well, there were all these atypical cells on the diff quick slide. I'm like, oh, can you send that? And then they're like, oh, I threw it away. So if you don't want that slide, then go ahead and send that as well, because we'll still look at it, even though like I personally don't love diff quick, but I will look at that slide, and sometimes it is the only diagnostic slide. If you want to keep it and have it for yourself to compare it to the report, that's fine too. But I would just say if you don't want it, then go ahead and send it, because we'll still look at that one. Keep in mind that mast cell granules may not stain very well, and whatever you do, don't throw the diff quick slide away. And then finally, not sending a patient history or information about where the sample was collected. So this is an issue for in-hospital samples and send-in samples. In hospital, it's easy to get a hold of people. Well, it's not as easy as I would like. And it'd be better if you just write the history and where the sample was collected from. Usually it says where the sample was collected from, but most of the time we do not have a full history. So just, keep that in mind. What would you want to know if someone was submitting the sample to you? And Dr. Sellen submits the best histories. So you can bug him about how he does that. But I think that the reason he does is because he understands the importance of us having a good history. And, he's thinking ahead. Like, I think, he's thinking about the differentials that we may have after we look at the sample and what other information about the patient might help us to like rule out some of those things, like that they don't make sense for this patient. And kind of like, I have a post in my Instagram about this for, perianal mass. We're thinking it's probably a perianal adenoma or an apocrine gland anal sac adenocarcinoma. So, apocrine gland anal sac adenocarcinomas are typically very easy to diagnose cytologically, but what's another piece of information that we may want to know about that is if they have hypercalcemia, because that's going to make us more confident in our interpretation. So kind of thinking ahead, like what might we want to know about this case to make us more certain in our diagnosis and help us interpret things. When you're labeling slides, they should be labeled with a regular pencil. So everything else does not make it through the stain very well. So pens, really bad. Markers, horrible. Patient stickers, do not love that at all. Red pencils don't really make it through very well either. So pencil, regular pencil is what you should label the frosted side of the slide with. If you, in general practice, not everyone has frosted slides because you can get the not unfrosted ones for free. Or they're like those kind that don't have very good frost on them. Not as frosty as the ones that we have in the hospital because those are cheaper. And so the writing can rub off of those. So I would still label them with pencil, but like the pencil is going to make it to us. But if you're worried, you can put them in different slide holders and like label the slide holder with what's inside. And then we have like a little diamond pen, I guess, diamond cutter thing to label the glass. And if you only have unlabeled slides, you may want to have that at your practice as well. I don't think they're very expensive, but it's just obviously you need to be able to label slides. And then write legibly. So sometimes, it'll be labeled like mass 1, mass 2, mass 3, mass 4, and I can't read the writing. And then even sometimes when I bring the clinician in, they can't read their own handwriting either. So just make sure that that is legible. Because, if one side looks like a sarcoma and one side looks like a lipoma, we want to know which is which. And then when submitting fluids, so this is for any fluid that you may submit for cytology, it should go in a purple top. And I'll talk about joint fluid and CSF in a second, the exceptions there. So the purple top is for cytology. So if you want us to look at the cells, if you want us to do a cell count, that needs to be in a purple top. And you can get away with submitting it only in a red top in the hospital because we're going to be processing it relatively quickly. But if you're sending it out or it's going to be, going through the mail, then you're going to lose a lot of cell integrity and it's going to be difficult. So for fluids, they should be submitted in a purple top, and we would prefer that here as well. So purple top, cytology, cell count, PCV, and protein. Red top is for chemistries, culture, and the exception for the joint fluid is it's better to do a mucin clot test on a red top. Often, you kind of have to make a choice what your priority is for. Usually the mucin clot tests, we're not going to like read a lot into that anyway. And if you're submitting joint fluid as a fluid, then you're interested in the cytology. So it's going to go in a purple top, but just be aware that the EDTA can interfere with the mucin clot test a little bit. And then chemistry, so for looking for gallbladder rupture, uroperitoneum, or chylous effusion, we can run bilirubin, creatinine, and triglycerides respectively, and compare them to the serum chemistry. So you have to have both that were done at about the same time. So it can't be like, oh, I ran serum 2 days ago. Can we compare it to that? No, you cannot. There are some chemistries that we can run on the purple top, but it's not ideal. It will affect the values, and we're comparing it to a serum sample. So, there's a little bit of not direct comparison there. If you have enough fluid, I would submit it in a purple top and a red top. But if you only have a small amount of fluid, if you know what your priority is, like my priority is cytology, or my priority is, I want to run bilirubin on this, I think that'd be kind of weird, but then that will determine what top you put it, what tube you put it in. And then for CSF, here we're submitting them in red tops at WSU currently, submit them in a red top. If you're out in practice, it needs to be put in a purple top. The only reason that is okay is because they're getting it processed immediately. So if you're mailing out a CSF sample, it needs to be in an EDTA. So when you're submitting samples, it'll ask you if you want to save slides for alk-phos stain. Basically, all that means is, is osteosarcoma a differential for what you sampled? If it is, then you should answer yes, you want to save slides for alk-phos. So staining for alk-phos, that's one of the only cytostains that it is the only cytostain that we have at WSU. It is one of the only times we can almost definitively say, yes, this sarcoma is this type of sarcoma. And so generally it's going to be positive for osteosarcomas. It can rarely be positive for other types of sarcomas. And importantly, it works better on unstained slides. So that's why we ask that question. If we have unstained slides, 1, it only takes 20 minutes, and 2, it's more sensitive. So if you don't say yes, save slides, sometimes we'll catch it if we see that it's like a sample from a bone, but not always. It depends on who's working. We have students and sometimes undergrads working the front desk that don't always have the knowledge to, make that leap. So if you want us to save slides for alk-phos stain, make sure you answer that question yes. So if osteosarcoma is a differential, you should say yes to that question. If it's not a differential, then you should say no. Sometimes people are like, I'll just say yes just in case, but then that's very confusing to have a yes say for alk-phos stain on kidney aspirates. And, whoever is working the front desk may not know that that doesn't make sense, and they'll save slides, and then I'll get it, and then I'll have some of the slides won't be stained, and I'll have to stain them, and that just takes additional time. So make sure that you're answering that question correctly. And then just quickly, I go over this a lot, but people constantly asking me about this don't understand the difference between neutrophil degeneration and neutrophil toxicity. So this is just sort of a review of that. And I have a number of Instagram posts and a number of 5-minute rounds videos about this. But basically with toxicity, this is a change that we're seeing reporting on the CBC. So you're only going to see toxicity reported on the CBC. It is a change that we see when neutrophils are being made too quickly. So toxicity happens when we have inflammation. That's it. It doesn't tell you anything about the inflammation. It just tells you that you have neutrophils that are being made more quickly. And so, like I said, it's something that we only report on a CBC. And the toxic changes that we see are Dolly bodies, which are the little blue aggregates, cytoplasmic basophilia, indiscrete cytoplasmic foaminess, and toxic granulation we'll sometimes see in large animals. Degenerate neutrophils are something that we report in cytology and fluids. So if you sample something, a fluid or an abscess, and we see neutrophils, then your next question, if you say, oh, there's neutrophilic inflammation here, your next question should be, are the neutrophils degenerate? Because that's going to tell you the most common reason is exposure to bacterial toxins. Not all bacteria create toxins that cause degenerate neutrophils, but a lot of them do. And so if you have neutrophilic inflammation, the next question is, do the neutrophils look degenerate? Because if they do, then you're going to want to look carefully for bacteria. You can also have some degeneration with exposure to irritating substances like urine or bile. And so this is typically reported on cytology reports for tissue or fluid samples. It is possible to have degenerate neutrophils in the peripheral blood, but do not think about that too much. So if you find intracellular bacteria, then it is considered septic. And the degenerate changes that we see, so the only change that you see with the degenerate neutrophil is that the nucleus gets swollen. That's it. And then the way that that looks is that because the swelling of the nucleus, with the swelling of the nucleus, the chromatin spreads out. And so we get more eosinophilic nuclei, and their segmentation becomes obscured because it gets swollen and you can't see those segments anymore. So the only change with degeneration is swollen nucleus, and the morphology changes that we describe are more eosinophilic nucleus and loss of segmentation because they have a swollen nucleus. So you only need to remember that one thing. I think we're getting to the end here. So getting your cytology report, just quickly kind of go over what happens. So your sample arrives at the window, we accession it, when we have time, but there's a lot going on in the lab. We don't always have someone manning that front desk. So staining takes about 15 minutes. Sample drying, usually we kind of let it dry on its own, takes about 10 minutes. Then sample goes to the resident about 35 minutes after arriving at the window. And this was if we had nothing else going on in the lab. Resident looks at the cytology, resident confirms the interpretation with faculty, and then resident posts the report. So this last step can take, if it's a mast cell tumor, it's going to take me less than a minute to tell you that it's a mast cell tumor. If it's something more difficult, it could take me hours. I may need to restain slides. I may need to look at it with my faculty for a prolonged period of time. So this part is very variable. I may be able to give you some very preliminary verbal information, but just be aware, like, it's not like, this was if there's nothing else going on in the lab. It even just takes me 35 minutes to get the sample. So that's why if you turn in the slides and then you come check back 10 minutes later and ask me what it is, I cannot tell you. So what really happens though, sample arrives. So what are some problems that we run into at each of these steps? Sometimes people ask me for the results of their cytology and I say, oh, I don't have the sample yet. And then they're like, I turned it in 2 hours ago, but it turns out it was never actually turned in and it's sitting in radiology. So make sure you turn in the sample. So at step 2, accessioning, sometimes there are no orders. So we do our best to get a hold of people if we have samples sitting around, but if we're extremely busy, that's not our priority. And so, make sure you're ordering your samples. Sometimes also the person to contact is not correct, and that that goes back to something I talked about on the first slide. If the doctor listed is not correct or we can't get a hold of that department, then it may just sit there until we hear from someone. The sample will usually sit here for at least 20 to 30 minutes, but if we're very busy, it can sit there for over an hour. So I try to pop out and when I have free moments and process things if we're understaffed, but just be aware of that. Things are not just like, the cytology samples are just like every other sample. They're sitting in line to be accessioned. Sample gets stained. So if we're very busy, then the slides have to wait in line because we don't have a slide stainer. So, this can add 30 minutes or more if we have, especially in the afternoon, we have, 5 samples of like 20 slides each that were just turned in. We can only stain so many slides at once, so they have to wait in line to get through that. And then sample dries, and then sample goes to resident. So, so actually, depending on how the day is going, the sample may not arrive to the resident until 50 to 90 minutes after it has arrived at the window. And then resident looks at cytology, especially in the afternoon, just like, the waiting to get in the slide there, I have other cytology samples to look at. So there may be a line of cytology samples. So I may not be getting to your sample as soon as it's turned in. Sometimes I try to kind of triage this and peek at things, make sure nothing is like septic abdomen or anything like that. Or see if there's anything that I can do quick verbals on, like mast cell tumors or lipomas, things like that. So I try to triage that a little bit, but just be aware like that I have a line of cytologies to get through, and I'm not doing every cytology immediately when they're turned in because it's just not possible. And then I have to confirm the interpretation with the faculty, and this really depends on faculty availability. So especially in the fall, sometimes faculty are in class and they're not available. And so for things that are not statted, then I'm not going to, you know, I'm just going to wait until they're out of class. So when things are statted during normal hours, then some of these steps we can sort of like, you know, usher the sample through more quickly, and that's what that stat is for. You basically are cutting the line in every way. And if you have a stat, you know, make sure that you ring the bell and tell someone at the window, and then post the report. So if you you know, if you think you should have a report and you don't, because I've already talked to you and I told you I was going to post it or whatever, make sure you let us know, because that's another, sometimes VADS just deletes the report. I don't know why. So let me know if you think your report should be posted and it's not, and I will post it for you. And then just in general, kind of, this is just for me. I try to give a verbal before the end of the day. Sometimes we get really slammed at the end of the day, and it's just like all I can do to get verbals out. And I, you know, usually if 5 o'clock starts rolling around, then I'm like, okay, I'm going to give everyone verbals, and then I'll write the report in the evening or early the next morning. And then I may ask, this would be something I would probably ask the residents more that are on the case, if they need a written report tonight, or if it's okay to have that in the morning. And then, so I may give you preliminary results or first impression verbally, but understand that this may change as I spend more time with the sample. If I say that I need to look at it with my faculty, then I need to look at it with my faculty. And then this whole side's kind of more for residents, but please read my report if you get transferred a case, or call me if the report's not posted yet or something doesn't make sense. So sometimes, you know, people get transferred cases and they just read the transfer report and there's something missing, but it's just right there in my cytology report. So if there is any confusion, please read the cytology report. And then for after hours cytologies, just understand that everything takes longer after hours. After hour cytologies are for emergencies, and I would really, really appreciate if you tell me if the patient died, because you know, it can sometimes take hours to do a cytology after hours because it takes a long time to send all those images through email to my faculty, and you know, take the pictures, and everything just takes longer after hours. So if the patient has passed away, then I would like to know. And so just, you know, in general, understand that we're a pretty busy lab and we have lots of different people coming in. We have vet student workers and some undergrad workers, and just multiple techs and people that may swing by the front desk to help you. So, you know, just make sure that you're communicating well with us. I will, when I'm on clinics, I'll have my contact information on the door outside. For looking at cytologies together, I think Zoom is still going to be the easiest for me, and that's going to be my preference. It's easier to, I think easier to look at the cytology over the camera anyway. And then for WSU students, don't forget that there are the 5-minute round files that are in the J drive if you want to get more comfortable with cytology and other ClinPath topics, and that's a good place to start. And so I'll get this posted and have fun on clinics.